Referral scheduling is often categorized as a basic clerical task, yet it remains one of the most persistent sources of front office stress. The standard workflow assumes a doctor writes a referral, the staff makes a quick phone call, and the appointment is booked. Operational data shows a far more complex reality. Successfully moving a single patient from referral to diagnosis requires a 7-step coordination workflow. Staff must verify insurance coverage, identify in-network specialists, and check availability, communicate details to the patient, follow up on missing documents, track if appointments were kept, and ensure findings are returned. Misclassifying this multi-step coordination as a side chore is a primary driver of administrative burnout and practice inefficiency. Peer-reviewed research helps quantify the problem. One study analyzed over 100,000 referral attempts across primary care networks. The results show a systemic failure. 65% of referral attempts never close the loop. Patients are not seen, and physicians make decisions without diagnostic information. For out-of-network referrals, the gap is total. 0% were documented in the EHR. While the paperwork stalls, the clock keeps running. The average wait time for a new specialist appointment has now reached 31 days. Patients spend this time waiting for answers, which research links to decreased quality of life and missed opportunities to slow disease progression. Incomplete referral loops result in delayed care and drive hundreds of thousands of dollars in administrative overhead and lost staff productivity. These failures are often the result of an operational bottleneck, the reliance on in-house generalists to manage specialized specialist coordination. Front office staff turnover hit 40% recently. Today, over half of all medical group leaders say finding qualified candidates is their single biggest staffing challenge. Every time a staff member leaves, the practice loses institutional knowledge of specific payer rules and EHR protocols. Replacing one administrative employee costs between 50% and 80% of their annual salary in recruitment and onboarding. These staffing gaps create immediate backlogs where referrals sit unprocessed for weeks, further delaying patient care. Hiring another generalist to solve the backlog often results in a cycle where the staff member leaves just as they become proficient in the workflow. To understand why this model is failing, we have to look at the fully loaded cost of a single in-house referral coordinator. It starts with a base salary, which averages around $35,000 for a clerical role. Then there is the overhead practices rarely track: payroll taxes, health insurance, and the physical cost of office space and equipment. You also have to account for the recurring costs of training and the financial impact of turnover. When you sum up the salary, benefits, and overhead, the total cost for one in-house coordinator is $60,800 per year. Spending $60,000 per position is a high price for a workflow that currently fails to close the loop 2/3 of the time. This expense maintains a system that is both financially inefficient and operationally unreliable. Smart practices are moving away from this model by outsourcing referral management to specialized virtual medical assistants. A dedicated Staffingly VMA represents an annual investment of $21,600. This represents a 64% cost reduction. By switching from an in-house hire to a dedicated VMA, a practice saves $39,200 per year. This model eliminates the risks of local turnover, recruitment costs, and the need for additional office space. These virtual assistants arrive with a practical competency advantage, having completed over 40 hours of orientation on specific EHR systems and payer rules. Outsourcing replaces the high overhead of physical staffing with a reliable, specialized service. High reliability is achieved by integrating the VMA into an AI-assisted workflow. Natural language processing extracts data from referral documents automatically, which prevents manual entry errors. Built-in duplicate detection identifies redundant entries before they reach the specialist's office. Predictive scheduling tools suggest the best times to contact specialists based on historical availability patterns. This environment is secured by enterprise-grade HIPAA, SOC 2, and HITRUST certifications for every account. Because the required training and security protocols are already fully pre-configured, practices can successfully go live in 48 to 72 hours. The combination of dedicated specialists and AI-assisted workflows provides a documented, reliable method for managing referrals at scale. For mid-size practices, the decision comes down to the bottom line: continuing with a high-cost, high-turnover status quo, or moving to a leaner model. The current model results in 31-day wait times and a 65% failure rate in loop closure. The alternative provides $39,000 in annual savings and a staff that is already trained on your EHR. Evaluate your current referral queue and the cost of your last 3 front office departures. You can plug these revenue leaks and stabilize your workflow in under 3 days by initiating a trial with Staffingly.